Hello, everyone, and thank you for joining us tonight. My name is Joe Kelly. I'm the program coordinator with the Rochester Hills Public Library, and I'd like to welcome you to this evening's Smart Towns program, Robotics and Surgery, presented by Dr. Douglas Pugmire, DO, and in partnership with Ascension Providence Rochester Hospital. Our next program will be coming up next Tuesday, October 5th. It's the history of Tiger Stadium, a love letter to baseball at Michigan and Trumbull, with author Doc Fletcher. You can register for that at calendar.rhpl.org. The program tonight will be recorded. It will be available on the library's website and YouTube page about 1 week from tonight. And as this is a Smart Towns program, just to briefly introduce the idea, Smart Towns is a lifelong learning program for everyone in the community, led by educational organizations in Rochester, Rochester Hills, and Oakland Township, Michigan. Smart Towns offers lectures, presentations, and courses to introduce participants to all aspects of the many educational topics they cover, and are presented by experts in their respective fields of study. And with that being said, I would like to introduce you to tonight's Smart Towns program and to our presenter, Dr. Douglas Pugmire. Please take it away.
Thank you. I'll probably end up wandering around here, but I'll start here. As the presenter said, Joe had said, I'm Dr. Douglas Pugmire. I'm a G1 oncologist. And so what's that mean? That G1 oncologist is a subspecialty of OBGYN. My training required obviously a 4-year undergrad degree, medical degree. I did a 1-year internship and then a 4-year residency and then a 2-year GYN oncology fellowship. I did the fellowship in Philadelphia at the Pennsylvania Hospital, which is University of Pennsylvania. And then from there, I came to Michigan to begin practice in 1997, so 24 years ago. And, robotics was not around, not even a thought of being around in 1997. Back then, we were doing about 75% of our cases as open hysterectomies, open surgery, and about 25% of our cases were being done laparoscopically. So as we go along here, you'll see that transition today, at least for me personally, we do, I would say 95% of our cases as robotic procedures, and maybe 5% of the procedures are done open. So it's a huge impact, at least in our specialty. I'll infer some of the other specialties that actually use robotics. Most or many specialties, such as urology, uses robotics a lot. But I would say in G1 oncology, I think the last statistic I saw that 75% of G1 oncologists in the country do about 50% of their cases robotically. So 75% of the G1 oncologists in my specialty will do half their cases robotically. So if we look back even further, back when I first went into practice, it was about 15% were done minimally invasively or laparoscopically, and the rest were done open. So, and we'll talk why that's significant. So we'll start with why this is significant and why this change occurred. So we'll talk about the GYN conditions. Many of the GYN conditions that we'll talk about will be benign. Robotic surgery has implications in both benign surgery as well as malignant surgery, and I am involved in both. So cancer surgeries. We'll talk about some of the symptoms and the treatments that are involved, some of the surgical options, as well as some of the medical options, and why robotic GYN surgery is being done today and how, including robotic hysterectomies, robotic myomectomy. We'll talk about what that actually means. Robotic hysterectomy for cancer surgery and why is it different and what does it look like difference-wise as it refers to the the surgery related to benign surgery as well as to cancer surgery, and what are the specific differences. And they're pretty different. So in urology, they do robotic prostatectomies. Many of those are radical prostatectomies. They do partial nephrectomies. Of course, prostatectomies are done for prostate cancer, nephrectomies for kidney cancer, cystectomies, which is removal of partial or the entire bladder for bladder cancer, and other urological procedures they do. The cardiothoracic surgeons, some of the cardiothoracic surgeons in the country have become world leaders. There's one at Henry Ford that was probably the first person in the nation, or one of the first people in the nation to perform robotic surgery. And robotic surgery has its roots in Michigan. Some of the top and first surgeons in the country in different specialties, urology, cardiothoracic surgery, and GYN surgery, began in Michigan and helped train countries, different surgeons at different countries, took robotics throughout the world, trying to bring this technology forward so that the advantages could be received by patients throughout the world. Colorectal surgery uses it for colon cancer. ENT, the ENT surgeons do it for ear, nose, and throat cancer surgeries, as well as benign surgeries, as well as general surgery, which was the last specialty to jump on board as a group. I mean, there was individuals that did general surgery robotically, but and probably the most gifted, minimally invasive surgeons in the world are general surgeons, but they were the last to jump on robotics because they're very reluctant for a lot of reasons, and we'll talk about some of those reasons. But general surgery now probably is a specialty that is ubiquitous as far as doing robotic surgery in the different procedures. And I would say gallbladder, hernia, any bowel type surgery, they're willing to attempt to do as a robotic procedure. Well, we're not going to talk about the other specialties. We'll talk about GYN and GYN oncology today. So for frame of reference, we're going to start with a little bit of anatomy so that we kind of are all talking about the same thing. Am I okay?
Yeah, I just want to check the mic.
A little bit closer?
I think it's giving a little bit of feedback. I just want to make sure it's all.
Anybody having difficulty hearing me, just raise your hand and I'll try to be clearer and speak up. So for reference, from an anatomical standpoint, we're talking about uterus, ovaries, tubes, cervix, and vagina. Some people refer to the uterus as a womb. I've never used that term, but some people do that. One of my mentors and one of the people who I admire the most use that term every day. When we're talking about the uterus, we're talking about the endometrium, which is the lining of the uterus, and the myometrium was the wall of the uterus. Fallopian tubes, I do have a pointer. Fallopian tubes, as seen on the picture here. Ovaries, which have the eggs, but there's a lot of different kinds of cells within the ovaries, and each of those cells, where they derive from, can develop different kinds of ovarian cancer. So when I think about ovarian cancer, probably when you think about ovarian cancer, you think about one cancer. When I think about cancer, I think of at least 25 different kinds of cancer that occur, and each one of those cancers are different kinds of cancer that have different prognosis and treated differently, and they're approached differently. And so when I know that information as to which kind of ovarian cancer it is, then I can talk to the patient more intelligently and talk to them about what their prognosis and what the treatment will look like, and their long-term prognosis as well as their short-term. As I said, the myometrium, the endometrium, we'll talk specifically about that because these areas, the endometrium, the myometrium, the sheath that surrounds the uterus, which is called the serosa, the ovary, etc., all these specific areas develop disease, some of those benign, some of those malignant, and very specific treatments for each. Cervix, When we think about the cervix, that's where women get Pap smears. Pap smear is a screening test for cervical cancer. It's not a test for detecting cervical cancer. It's actually a screen to get precancer, so to pick up precancer. And we'll talk a little bit about that in a few moments. And then, of course, the vagina. When I think about these anatomical areas, uterine cancer, about 60,000 endometrial cancers. There's other kinds of uterine cancers that are not endometrial cancers, such as something that arises from a uterine fibroid that's a cancer. It's called a sarcoma. Those are pretty rare. The vagina is probably the least. Vagina and the fallopian tube has the least amount of cancers involved with it. But I would say about 1,000, between 600 and 1,000 cases each year for those cancers that are diagnosed in the United States. Interesting part about cervical cancer in the United States, there's about 11 to 12,000 cervical cancers in the United States diagnosed each year. In the African continent, 500,000. It's kind of crazy. And the only difference is Pap smears. Routine Pap smears performed in the United States changed at the turn of the century in the 1900s by the use of the Pap smear. So some of the gynecological conditions we're going to talk about is a fibroid. It's the most common reason why hysterectomy is performed, but there are other treatments for fibroids. They're actually called leiomyoma. It's the medical term for that, but uterine fibroids is the more common term. We'll talk about pelvic masses, and when I think pelvic masses, that could be a fibroid, could be a pelvic mass. Largest fibroid that I've ever removed from a patient is about 30 to 35 centimeters, so bigger than a basketball. Abnormal bleeding, some of the conditions we also address, and those abnormal bleeding could be from fibroids or it could be from other causes, could be from cancer. Endometriosis, most common cause of infertility is endometriosis. We'll talk more specifically about endometriosis. It's also the most common cause of chronic pelvic pain. 3 diseases cause chronic pelvic pain. The syndromes of chronic pelvic pain are endometriosis, uterine fibroids or leiomyoma, and something called adenomyosis. And basically what that is the lining of the uterus grows into the wall of the uterus, which sounds like cancer, but it's benign. It's actually local endometriosis involving the wall of the uterus. And we'll talk more specifically about endometriosis and how that occurs and why the patients get pain and discomfort. Pelvic floor disorders, when I'm usually referring to this, I'm referring to those people who have uterine prolapse, where the uterus is falling out of the pelvis, or vaginal prolapse. And that's a big whole field that's called urogynecology, that they address that mostly. Precancer, obviously I deal with this, precancer, which is diagnosed with Pap smears. And then of course cancer, endometrial cancer, cervical, vaginal, vulvar, fallopian tube, ovarian, and primary peritoneal. So the lining inside the abdomen is called the peritoneum, and many times a cancer will, a perfect example of that would be patient develops ovarian cancer and doesn't have ovaries. That's called primary peritoneal carcinoma. And so that can occur. How can somebody get a cancer when an organ's not there? Well, the cells originate from the ovarian cells, and the ovarian cells are on the ovaries, but they're also on the pelvic lining along the pelvic side wall. So cells that, you getting some feedback, some more feedback?
I think I'm going to change the batteries.
Okay. Can I use this one?
That one I think is dead. Okay.
And so these pedunculated fibroids, so one of them's inside the lining of the uterus. Let's see if I get this right here. Yeah. So this one here, this pedunculated, means it has a stalk. This one also has a stalk, but this is in the lining of the uterus, which it's a submucosal fibroid. This other one out here is a serosal pedunculated fibroid. So those names are there, just for reference. So these symptoms these patients have: bleeding, it can cause infertility. So many times we'll do surgery and preserve the uterus and take out these fibroids. It can lead to, obviously, as they get bigger, they can compress the bladder. The patient has increased urinary frequency, or they may have bowel changes such as constipation. Many times it's constipation, diarrhea, kind of alternating. So sometimes it's confused with IBS or irritable bowel syndrome. Pressure and pain, obviously, as a mass uterus gets bigger, they have pressure and pain. Treatments, if the patient has no symptoms, I think the literature says that up to 75% of women will have some fibroids. They can be tiny and be asymptomatic. They can be even large and be asymptomatic. And so for the treatment for those, for asymptomatic fibroids, is to do nothing. You do not have to do anything. What popped in my mind immediately is, well, what about a patient who has a fibroid, that, or quote unquote fibroid diagnosed on a pelvic ultrasound, but is changing over time? Still, the patient remains asymptomatic. So I'll take a 50-year-old who has a fibroid that measures 6 centimeters. It's in the wall of the uterus, and the patient has no symptoms. Well, that patient doesn't have to have anything done if they're not having any bleeding, not having any pressure, discomfort, etc. But what if that fibroid is changing over time? It's changing over months. It's doubling in size. That has a lot more significance to it than a fibroid that doesn't change. Patient who's in her 50s, or take another patient who's in her 60s where that's occurring. So fibroids grow by stimulation from estrogen. So they have estrogen cells in them that ovaries are producing estrogen and causing them to grow. So premenopausally, not uncommon for them to grow over time. But once you become menopausal, many times those fibroids will either stop growing or regress. So if that's not occurring, it's usually an indication that something's amiss. So there are medications to shrink these fibroids so these patients can, avoid surgery or attempt to avoid surgery. Usually that medication is used in conjunction with the plan that there's going to be surgery down the road. Because you can't take this so this medication puts the patient in a menopausal state. So you take a 28-year-old who has a 10 centimeter fibroid, and 10 centimeters pretty large. You want to try doing it minimally invasively, and you want to shrink it down so that you can make it, so it'll shrink the tumor, the fibroid, up to 60% over 3 months. And so you can give them this medication, shrink it, make it 4 or 5 centimeters, and make it more likely it can be done minimally invasively. But it makes them menopausal, or gives them menopausal symptoms temporarily. And because it does, you can use it up to 6 months. There's some data that says you can use it even longer if you add back a small amount of estrogen. And it's because the bone demineralization, some of the downside for the lack of estrogen in a premenopausal patient. Uterine artery embolization, that's a interventional radiology procedure where they catheterize into the iliac artery, get a catheter up into the uterine artery, and then they use a embolizing medication that blocks the artery to the fibroid, and it can shrink it. It is fraught with a lot of failures and a lot of symptoms. Patients get low-grade fevers and have a lot of discharge when they do it, so it really hasn't caught on as a very good procedure. Interventional radiology also can directly access the fibroid and either freeze it or ablate it, use thermal ablation, use energy and heat it up and destroy it that way. not very commonly done because of, once again, the side effects related to it. Surgical options, this is where we all these patients, they've passed all those things. When I see them, by the time I see them, they've gone through all their medical management. They've attempted minimally invasive type procedures, not surgical procedures, but non-surgical, or they've done a procedure, but not a surgical procedure. So we can, when we get to our point and these patients want to have these fibroids addressed, it's one of two ways. The patient wants to maintain the ability to become pregnant, or they do not. And so that's the first question that we usually ask. Sometimes it's not as clear. Maybe a 60-year-old who has a big fibroid who just wants to get her fibroid removed. We don't do that very often. We feel that it's a temporary fix. Those patients who do it during premenopausally or during the time period where they can become pregnant, it's only a temporary fix. It only is good for fertility for about 12 months after the procedure, or their best option for pregnancy is in that first 12 months. After that, it's no longer beneficial. So when you do a myomectomy or you remove a fibroid in a postmenopausal woman, that, you know, there's issues in the sense that, well, that patient's likely going to end up having a major procedure such as a hysterectomy down the road. I think the important thing to point out here is a woman who has a fibroid who wants to get the fibroid removed and become pregnant. That patient is committing to probably 3 major procedures: the myomectomy, the C-section. They have to have a C-section for delivery of a pregnancy, and they probably still are going to end up getting a hysterectomy. So it's a big commitment to a patient. So I always tell them, look, you're committing to 3 surgeries. So if you have a patient who has never had children and is, you know, say she's 32 years old, no children, wants to have children, then you're going to be more aggressive about getting that fibroid out, preserving the uterus, ovaries, and tubes, and making it more possible that they can become pregnant. Whereas you have a 60-year-old who obviously is not going to get pregnant ever, we're going to try to lead that patient or recommend to that patient that they get a hysterectomy and not a myomectomy. So we can resect these fibroids, these ones inside the lining of the uterus, these pedunculated ones, or these what are called submucosal fibroids. Those are resected with a hysteroscopic resection, which that means is a small scope, a hysteroscope, a scope that goes through the vagina, through the cervix and the cervical canal, and into the endometrial cavity, and then we use a scope that's able to resect those fibroids, and that's fairly simple to do. Myomectomy, where we remove the fibroids on the outside of the uterus or in the wall of the uterus, intramural or subserosal. Once again, fertility is the important component of that, and if then fertility is not an important component, then we recommend a hysterectomy. Ovaries or no ovaries, that depends on multiple factors. So what is endometriosis? Endometriosis is endometrial tissue outside the uterus. So endometrial tissue outside the uterus, well, as I talked about, adenomyosis, the lining grows into the wall of the uterus. So adenomyosis has similar symptoms. It makes the uterus bigger. It creates abnormal bleeding, either heavy menstrual periods, bleeding in between periods, and pressure in the pelvis. And then, of course, you get endometriosis with implants, such as this here. You get adhesions or scarring. Basically, we did a case yesterday where the patient probably in her lifetime had endometriosis. Many times endometriosis is completely asymptomatic, and we're operating this patient who has endometrial cancer, and she's only had one previous surgery before where she had a quote-unquote a cyst removed from her ovary, and her pelvis was essentially fixed. Everything was stuck to everything else. Really unusual to find that. Our average patient has 3 previous abdominal surgeries. This patient only had 1, and it was a small ovarian cystectomy, removal of the cyst, and her pelvis was a complete nightmare. We did it robotically, and It was very difficult. So these patients with endometriosis, they usually have pain. Like I said, it's one of the pain syndromes, chronic pelvic pain, or CPP. They always have pain. It's pain before periods, after periods, during periods. Pain during bowel movements, during periods. We already talked about pain during and after intercourse. Dyspareunia, that's the term, dyspareunia, pain with vaginal intercourse. It's kind of what they determine as pathognomonic. If they have pain with vaginal intercourse, especially deep penetration vaginal intercourse, it's usually going to be endometriosis. And of course, infertility, one of the number one causes of infertility, endometriosis. So most of the REI, or infertility doctors, see a boatload of the infertility patients with endometriosis. And you know, the infertility doctors are IVF or in vitro fertilization is kind of their big procedure. They're not big time surgeons, and so when they get really difficult, what they call stage 4 endometriosis, it's just everything's fixed to everything else, they usually will send the case to us to remove the endometriosis and preserve fertility. Regular vaginal bleeding, these patients' menstrual periods are many times a mess. Some of the treatments, so once again, these patients have gone through all this, but in reference, pain management for these patients, oral contraceptives is usually the first try in controlling some of the discomfort that the patient has. Pain medications, including narcotics and ibuprofen. Medical therapy, once again, you can use a medication that causes menopause. So once again, estrogen stimulation is the cause of this. There's estrogen receptors in the lining of the uterus, that endometrium, and that's the cells that are implanted inside the intraperitoneal cavity. On the ovary, if it's on the ovary and you create a cyst, it's called an endometrioma. So we had a patient this morning who has, it's an interesting case, so she's in her 30s, mid-30s, and she has bilateral 9 centimeter, so baby's head is 10 centimeters, so these were 9 centimeter bilateral ovarian masses. A known history of endometriosis, which means that she had surgery in the past. Somebody did a biopsy, proved that she had endometriosis. She also had some what are called tumor markers. They're tests for ovarian cancer. It's called a CA-125, and anything above 35 is abnormal. Her CA-125, I think it was in the 250 range, so significantly elevated, and she wanted to do nothing but pain medication, narcotic pain medication. I said, well, you're not getting pain medication unless you're going to address the cause of the pain. You know, we'd already given her pain medication so that she could take a week or two to decide if she wanted the surgery. Now, she was referred to me to have surgery, so it was a little bit confusing. So we just said, look, why don't we address your issues so that you won't have pain, so we can do the surgery, remove the disease, significantly reduce your pain, and then you may not even need any pain medication. So, as I said, medical treatment can be some of these GnRH agonists. It's called Lupron. There's several other ones that are used as well. There's other oral medication that's our antagonists, GnRH antagonists. They're also used for this, and they just work and put in the patient into menopause so that they can have less stimulation, and it may suppress the growth or shrink the disease and decrease the amount of pain. Short-term use, though, 6 months, maximum 2 years, and the patient can't get pregnant, obviously, during the use of that. These patients who are being treated for endometriosis, generally either it's a fertility or not fertility question. So they either need or want to get pregnant, or they do not. And the ones that do not, we address it definitively, and we'll talk more about that. So the surgical options, you can resect it, you can ablate it, you can use energy, argon beam, CO2 laser. I mean, there's a lot of different techniques that are used. We do not do ablation, we do resection or removal. We do a definitive procedure usually. So hysterectomy is kind of the area that and I mean by hysterectomy plus ovaries and tubes. So I'll take up, for instance, a patient who's 28 years old who has done 10 cycles of IVF. They've in vitro fertilization, have not got pregnant or got pregnant and lost those pregnancies. And the patient's overall consuming moment is to control her pain, to have pain control, and has accepted the fact that she's probably not going to get pregnant. That patient's pregnancy rate is extremely low at that point. Maybe she's been operated 6, 7, 8 times, trying to resect this, maintain fertility, decrease her pain, and make it more likely she can get pregnant. And they come to me, they're at the end. They've consumed or exhausted everything that they want to attempt to do in a fertility setting, and they're willing to do a definitive procedure. And that would be uterus, ovaries, and tubes, and resection of all the endometriosis that's possible. To me, endometriosis surgery is more like cancer surgery than pretty much any other surgery that I do, very much, because it spreads very similarly. It's staged like cancer, staged like ovarian cancer. It has a staging system, 1 through 4, like ovarian cancer, and it affects the anatomy in a similar fashion. The upside is it is not cancer. It's interesting. So they can travel to the lungs. You can get it can transfer into the nasal passages through the blood system. It's been reported to be implanted in the brain and then bleed monthly. So it's a really strange disease. Sounds invasive, but it is not a cancer. Doesn't act like a cancer in any way, shape, or form. So here's the good news and the bad news type of situation. Endometriosis is paradoxical, meaning that those who have the least amount of disease usually have the most amount of symptoms, or they have the worst symptoms, the most painful symptoms. And the patients who have the stage 4, the worst disease, usually that has destroyed the nerves and they have less pain. So those patients I describe as having a fixed pelvis usually don't have near as much pain as those that have lesser disease. It's an interesting, crazy disease. I've always had an interest in that disease, and we do a lot of endometriosis surgery because most of surgery that would have been done and is still being done is done open on these patients, and we're able to do it minimally invasively, and we'll talk about why that's so beneficial. So pelvic floor disorders, where the uterus basically falls out of the pelvis. It's a crazy disease as well. What causes that? That's being menopausal or the lack of estrogen, childbirth, vaginal childbirth, pelvic trauma of any kind, including surgery. So more surgery you have, the more risk there is in the uterus, the bladder, and the colon falling out of the vagina. I've seen a patient where the uterus was on her thigh, completely out of her pelvis and on her thigh. So pretty crazy to think about. You say, how does that happen? If all these ligaments and muscles lose their strength, they just drops right out, or can drop right out. Most patients don't wait till it's down on their thigh. Most patients will wait when it's, what's this thing poking out of the vagina? And that's usually at the latest time period. But, elderly women, maybe in their 80s, who, say, well, I'll probably die before I have to worry about this. And then it seems to, quote unquote, accelerate over the last couple of months, and that's when they show up. Well, I can't kind of do anything now. So they come and have to have something done. We'll talk more about that. So all the organs can fall out. And you have to address all these if you're going to address this properly or correctly. And, I have some opinions about that, but we'll talk about that. So here it is, falling out a little bit. They grade these. Medicine has grades and stages for everything. So we grade these. When it comes to the opening, what they call the endometriosis, the opening of the vagina, or the opening from the vagina to the outside or to the vulva, that's grade 2 and out is grade 3. Most of the patients we're doing are grade 2 or 3, obviously. I mean, if they have a grade 1 where it's just, halfway down, this is kind of between a grade 1 and grade 2, those patients are most likely over time, or potentially over time, without doing anything, going to develop worsening disease, and it'll go into a higher grade. So the symptoms, as you can imagine, heaviness, feeling that something's falling out. In fact, they almost always say that it feels like something's coming out of my vagina, like I'm delivering a baby. These patients can have pelvic floor prolapse with uterine fibroids, usually not with endometriosis because that's going to scar everything up in the pelvis and kind of hold it up. Pain during intercourse, uterus is not in the right place and it starts falling out. Anal pressure, as the colon or the rectum, the rectal sigmoid colon can fall out. Patients describe many times as pushing, when they have a bowel movement, as pushing the vagina back out in order to defecate. They have low back pain, incontinence. Most of these patients have to have their bladder suspended after putting their uterus or we usually don't put the uterus back up. We usually will take the uterus out and have to address the bladder because it's fallen out as well. So it's interesting. So you get the uterus coming out, and eventually the urethra, the tube from the bladder to the outside, gets kinked. And so initially they'll have some incontinence with coughing and sneezing, and then the urethra gets kinked and they no longer have incontinence. My incontinence is fixed, except for the uterus is falling out. So they try to push it back up, and we'll talk about it. You can put a pessary, and I'll talk in a second, where we put this ring, this different materials, but it's a ring, and it basically holds the uterus up. Those patients, it's a temporary fix. You can't just put it up there and forget about it. It has to be changed out. You have to take it out to have vaginal intercourse, and it is not the best scenario. Most of the patients we see have used a pessary either for years, or they tried to use it and it was just too painful to use. You can do pelvic floor exercises. You can send these patients to a physical therapist. There are some physical therapists, that's all they do is pelvic floor exercise with patients who have this disease, and they try to prevent them from getting surgery, which is great. If you can avoid surgery, so much the better. Pessaries we talked about. And there's a lot of different kinds. There's hundreds of different kinds of pessaries, and they all work a little bit differently. But the most common is a ring pessary. I don't even know how to describe it. It's just a ring. It's a plastic ring, kind of very flexible, and it fits underneath the pubic bone inside the vagina. It goes in the vagina, usually initially placed by a physician, but if the patient can do it, at some point they have to get comfortable with putting their fingers up into the vagina and then put it under the pubic bone and against the sacrum, the back part. And not too many patients are really comfortable with that. They're not. So occasionally you'll get patients who are motivated and willing to do that, but for the most part, not so much. Surgical options, obviously the uterus is a heavy organ, especially if it's a diseased uterus, it'll fall out. If you try to fix this disease with leaving the uterus in, it most likely will fail. So most of the time a hysterectomy is done. Vaginal vault suspensions, there's a couple different kinds. You can do them vaginally or you can do them abdominally. We do the abdominal one, and it's done robotically. So the big, back in the 90s, so these procedures have been around for 100 years. It's hard to imagine these have been around 100 years. They've been around. The abdominal procedure has been around exactly as it's described today, except with the materials are a little bit different, for at least 50 years. And so they're huge long-term studies that have shown which one of the two, the one done vaginally versus the one done abdominally, which one's best, which one works best, which one creates the least amount of complications and has the best long-term outcomes. And the abdominal one, so in this country, the United States, we had 50% of the GYNs did an abdominal approach and 50% did a vaginal approach, until robotics came along and changed the world, where you could do this minimally invasive with robotic surgery, and it no longer was even a question about. And the reason, and I didn't say this, but the reason is the abdominal one was significantly better for not only short-term and long-term complications, but for long-term outcome regarding the satisfaction of the patient. So vaginal vault, so the one done vaginally, you basically sew the vagina to a ligament, and it kind of pulls it off to one side or the other. Kind of a difficult procedure with some risk associated with it. We do not do that one. Can I do it? Yes. Do I recommend it to the patient? I usually steer them away from that procedure. Usually vaginal surgeons. We used to have a vaginal surgeon at our hospital. Excellent vaginal surgeon. I would say, top 5% in the world. I mean, that kind of good. Very good. And he did this procedure. He had good outcomes. He did a lot of them, so his experience was good. But bottom line is those took hours to, 4 or 5 hours to perform. Blood loss, etc., was high, and satisfaction wasn't as high as it was with the procedure that we do as a minimally invasive robotic procedure, and it's called the sacral colpopexy. The one he did was a sacral spinous fixation, and not to get too complicated, but it's just sewing the vagina to a ligament down against the sacrum, and we take a piece of mesh and sew it to the top of the vagina and attach it to the sacrum, and it's there permanently. It scars in, and it's the whole procedure takes about an hour, maybe an hour and 15 minutes. Knock on wood, I have not had to transfuse a patient with that procedure. It just doesn't have the risks that the vaginal procedure has. So vaginally, abdominally, I don't think, there are still people who do this as an open abdominal procedure. I think most of the country and most of the experts who do this procedure do it as a robotic procedure now. Some people were doing it laparoscopically. In fact, one of my trainers in Philadelphia, he did this as a laparoscopic procedure. He had good outcomes. It wasn't technically the same kind of procedure, but it was, the same procedure. It just wasn't as technically sound as the robotic procedure that we do today. The one we do today is the same procedure that was described 50 years ago by the guys that created this procedure. So, ultimately, it's an abdominal procedure that is now done robotically. In fact, most of the robotic surgery that we do is abdominal surgery that is now done minimally invasively. I mean, that's where robotics has changed the world, because it's changed all those open procedures. 75% of those cases that were being done open now can be offered as robotic or minimally invasive. So an open abdominal sacral colpopexy with a mesh and all that would be a 4 or 5 hour procedure with a 20% transfusion rate. In fact, I did a paper on comparing open sacral colpopexy against laparoscopic sacral colpopexy, and the transfusion rates were way higher. So the bottom line is that these procedures are just converted from open abdominal, big vertical incisions, or like a C-section type incision, to do these procedures. And it depends upon the anatomy, which incision, how big is the uterus, and what anatomy is going to be involved, what kind of procedure you're going to do. And that's planned out before you even start the surgery. So laparoscopically, I just don't think the laparoscopic approach was like the abdominal approach, and so it's had some drawbacks, etc. I mean, it's difficult to learn how to do laparoscopic surgery to that extent, and hopefully by the end of this, you'll see why that's the case. When we start talking about costs, a robot costs $2.5 million. So you really can't you can't compare, when you compare laparoscopic surgery, even if they use, disposable instruments, which are expensive, to use a different disposable instrument every time you do surgery on a laparoscopic patient. I mean, ultimately, it's hard to make that comparison because a robot's so expensive. Its initial capital cost of $2.5 million. I will defend the robot and say, okay, well, that may be true, but we purchased here at Ascension Providence Rochester, or formerly known as Crittenton, we purchased the 3rd generation robot in 2010. It was called a SI. And that was around 2 million, maybe 1.8 to 2 million at the time. And we used that. We just retired that robotic piece of equipment after 5,000 hysterectomies, 5,000 procedures on it over a 10-year period. So they last a long time, or they can last a long time, and they're used by every specialty. So the bottom line is, if you break that down into those number of cases, actually the costs are relatively comparable. We're not going to get into costs, but I at least wanted to mention, I'm aware of the costs. I'm aware of cost analysis related to this. When you actually look at the costs, it actually is in favor of the robot, which is hard for people to grasp because we're using just the length of the procedure. The length of the procedure robotically is essentially significantly less. So if you compare a laparoscopic procedure to a robotic procedure, it's at least half the amount of time required. And every minute in the OR, the patient under anesthesia is extremely expensive. So an extra 60 minutes is over $6,000 for a patient. So the bottom line is it's a huge difference if you just look at that specific cost of benefit analysis. So we'll move on. So robotics, we'll talk more about. So bladder suspension for bladder, I kind of alluded to this, that when we do these sacrocolpopexies and elevate the apex of the vagina with a piece of mesh, we also have to elevate the neck of the bladder. That's a vaginal procedure. So we make a small incision on the vagina near the urethra at the junction of the bladder and the tube that comes to the outside. And that we always do that. The only reason why we do that is because there's a 30% chance. I used to not do it. I used to wait. So, okay, we're not going to suspend the neck of the bladder because there's only a 30% chance you'll actually leak after this procedure. They said, okay, yeah, that's fine. That makes sense that you're not going to do a procedure that I may not need. I'd do that, and then the patient would leak, and they said the procedure failed. And so I said, well, look, here's the deal. Why don't we do it this way? We'll just do the procedure, and I know that you won't leak after the procedure, and the procedure didn't fail. But that was only for 30% of the patients. So we're doing the procedure on 100% of the patients because 30% of the patients potentially will leak. The problem is we're not sure which ones will, and there's no way to know. So at this present moment, until we're able to tell which ones would leak and which ones won't, then we're going to do the procedure. You think about it. You got to take them back for a second anesthesia. You have to, it's a big deal to go under anesthesia again. It's going to add a little bit more. It takes me 15 minutes to do procedure. It has minimal risk to do the procedure and all the benefits that it won't leak. And even if the patient didn't leak afterwards, is it possible that they'll leak down the road? And the answer is yes, it's possible or probable. So pre-cancer, this is kind of, Pap smears, et cetera. These are the, we want to diagnose these patients before they become cancer. So this is, 30% of the people that come into the GYN office will be coming because of abnormal Pap smears. Common condition, can be prevented. There should be 0 cancers involving the cervix in the United States. 90% of the people who develop cervical cancer have not had a Pap smear in 5 years or greater. Now, obviously, the recommendations for Pap smears have changed quite a bit, but the bottom line, if you're following the recommendations by all the major groups, American College of Obstetrics and Gynecology, et cetera, then you're not going to run into problems with cancer. Yeah, there's some false negatives and positives, and that can increase issues. But the bottom line is if you're following those recommendations, you have a 99.9% chance that you won't develop cervical cancer. So these abnormal cells, they're called dysplasia. It's a continuum of disease from mild to moderate to severe to carcinoma in situ and then cancer. And that takes years to develop, years to go through that whole process. And then you also have to have HPV, most of these patients will have HPV, and HPV are human papillomavirus, is the cause or etiology of cervical dysplasia and cervical cancer. So most clinicians are not only doing a Pap smear, but they're doing HPV testing on those Pap smears. And that helps to triage the patients. Like if you have pre-cancer Pap smear that has negative HPV, it has one implication versus those who have high-risk HPV viral types. And we manage them completely differently. Pre-cancer inside the lining of the uterus is called endometrial hyperplasia, or it also has another name, EIN. I won't tell you what that means. Just pre-cancer of the endometrium. And it has symptoms. Any of these symptoms for the dysplasia of the cervix or hyperplasia of the endometrium. Dysplasia of the cervix has no symptoms. Hyperplasia has bleeding, postmenopausal bleeding usually, or abnormal bleeding, because you can get this pre-cancer of the endometrium in premenopausally. And it's usually women who have polycystic ovarian disease, so they usually have other issues. And I'm not going to get really into that, but just know that asymptomatic for dysplasia, usually picked up by a Pap smear. You're not going to say, hey, doctor, I think I have cervical dysplasia. The doctor will say, hey, we did a Pap smear, it's abnormal. You're not going to have symptoms. Endometrial hyperplasia, on the other hand, you're going to have symptoms. You can have bleeding, heavier bleeding, bleeding in between periods, irregular bleeding, etc. And these usually can be diagnosed with an endometrial biopsy in the office. If it can be done, sometimes it can't be done, and then they have to go to a DNC. But you don't need to have both. You don't need to do an endometrial biopsy and then a DNC. You just need a biopsy to say that it's one or the other, benign or malignant, benign or precancer. So treatment options for precancer, for cervical dysplasia, usually we do a conization or a LEEP. Those are just basically a rod with a wire. It kind of looks like a small cheese cutter, and it just cuts off a portion of the cervix. It's called a LEEP procedure. It's an acronym. And a cold knife conization is a scalpel blade where we cut out in a circular fashion the cervix. We do almost always a cold knife conization, which is exclusively for grade 3 dysplasia, high-grade dysplasia, or carcinoma in situ, so that the margins are not destroyed by the cautery. The scalpel blade doesn't burn anything, obviously, and so it can be read by the pathologist better. Endometrial hyperplasia, usually treated with hysterectomy. Occasionally we'll get patients who want to maintain fertility. I have several patients right now who want to maintain fertility. And there's some good data now about using a hormone, like a progesterone agent, suppress. Not supposed to really do it in endometrial cancer, but you can, there's some data that says that you can put an IUD with a progesterone agent in the IUD, which is a kind of a T-shaped apparatus, that small apparatus goes inside the uterus, or you can just give them an oral progesterone agent and then they can be sampled. You usually have to follow those patients very closely. It's a pelvic ultrasound every 3 to 6 months with a biopsy, endometrial biopsy every 3 to 6 months until normal. And as soon as they're normal, then they need to go to the reproductive endocrinologist, the infertility doctor, and attempt pregnancy, and then get through their pregnancy and they get a hysterectomy. It's never, even if they go back to normal, they always need to get a hysterectomy. They call that a completion hysterectomy. So those patients will get a hysterectomy, just a matter of time. Female cancers of the reproductive organ are common, or are uncommon. They're not common. You hear about ovarian cancer and endometrial cancer, and they're 60,000 cases. When we talk about colon cancer and lung cancer and breast cancer, there's 200,000 people who get cancer, those cancers, and endometrial is the biggest cancer that we have, and that's 60,000. So really kind of uncommon. So these patients have intermittent bleeding, irregular periods, bleeding after menopause. Any of these cancers, you can get this pink, watery, bloody, any kind of discharge like that. You want to be looking for a cancer. Usually that particular one, the pink, watery, bloody vaginal discharge, is related to fallopian tube cancer. Patients can have pain. I have a patient, not even my patient, a colleague, fellow worker in the hospital this week came up to me and she says, I think that something's going on and, they won't do anything. They won't, I have bloating and pain and discomfort and low back pain. And I said, well, you just need some imaging and then we can examine you and, just not ignore you. We need, because sometimes, many times, there's something going on, whether that's malignant or benign. So I'd just be persistent about it. As a patient, you just need to find somebody who will listen to you and get imaging. And that can be a pelvic ultrasound, a CT scan, an MRI, whatever. I don't really, if I had a preference, I'd say probably a CT scan. CT scan gives me a lot more information and much quicker time period. It's easier to have performed. You just scan that patient through and you get the results right away. Each one of those has a very specific area where I definitely use it. Like for instance, endometrial hyperplasia, I want to measure the lining of the uterus, pelvic ultrasound 100% of the time. So I'm not bashing the other two. I'm just saying CT scan. If I have one to pick of the three, I'm going to pick a CT scan. So that person I talked about at the hospital who came up to me, I said, yeah, well, we can order a CT scan and start from there. We can get some lab work. If there's a pelvic mass and we have a tumor marker for ovarian cancer, that will help us to try to make a diagnosis. Bleeding after intercourse or post-coital bleeding, that's usually very pathognomonic or one of those indications that red flags cervical cancer. Irregular bowel function, bladder function, abdominal pressure, bloating, those symptoms are more consistent with ovarian cancer. So endometrial cancer, this is the lining. Once again, the endometrium. It's anywhere in here. Endometrial cancer. Once again, we already said most common, GYN. If you exclude breast, it's the most common. Usually detected in early stages. 50 to 60% of these patients will have surgery will be curative. So there'll be stage 1. If most of these patients, they start having postmenopausal bleeding, they go to the doctor, you get a biopsy, shows endometrial hyperplasia or endometrial cancer, and they get a hysterectomy. It's about like that, and it should be about like that. It should never be told, especially a postmenopausal woman, it should never be told that any bleeding is normal. Any bleeding is absolutely abnormal. So, and should always end with a biopsy of some sort. Cervical, endocervical, endometrial biopsy. Most common cause of postmenopausal bleeding, always treated with surgery. So the thicker the lining of the uterus as measured by ultrasound, as you get thicker, it's more likely for there to be cancer. So as you increase your age, there's a paper on this, as you increase your age and increase the thickness of the lining of the uterus, so the normal lining postmenopausal is less than 4 millimeters or less. So if it gets 1.5 centimeters and the patient's 80 years old, she has an 80% chance she's going to have endometrial cancer. And I can tell her that the moment I meet her. So your endometrial or your lining of your endometrium on ultrasound's 1.5 centimeters, you're 80 years old, you have an 80% chance that you have endometrial cancer, we need to do a biopsy. They're more likely to respond to that and say, well, you might have endometrial cancer, and yeah, you have bleeding, and it may be due to a polyp or something else, but we're here to rule out cancer, so let's rule it out. So that's how we kind of go about that. Cervical cancer, so the cervix down here, it says here, can be detected by a Pap smear, but a Pap smear is not the way to detect cervical cancer. Pap smear is present and exists to diagnose dysplasia or precancer. So hopefully I'm emphasizing those so those take-home messages, you can spread the word. So if I see an abnormal lesion on the cervix, I'm not going to I probably would do a Pap smear, but I also would do a biopsy. So the patient has symptoms, she has postcoital bleeding. The most common symptom with these cervical cancer patients with a mass. I put a speculum and I see a mass, I do a biopsy. I'll tell you a story. So when I first got into practice over in Lansing, the patient had over a year period of time, she had 3 or 4 ultrasounds and 3 or 4 Pap smears. And every time she went to the ER every single time. Every time she went to the ER doctor looked at the cervix, commented that she had a very abnormal looking cervix and somebody should biopsy that. And so eventually she got sent to me. I looked at her and said, "You have cervical cancer." When I was looking at the cervix, I said, "That's cervical cancer." I did a biopsy and it was cervical cancer. And unfortunately it was stage 4 cervical cancer. And so she was not particularly happy with the care that she had gotten previous. The bottom line is, well, I heard from these doctors, well, the Pap smear was normal. Your Pap smear, the 4 Pap smears that she had done within the past year to year and a half were all normal. So why did you think that was cervical cancer? Once again, Pap smear is not for cervical cancer, it's for precancer, and that somebody who has cancer, and I can look at an abnormal finding on cervix, I do a biopsy. Same thing is true of the vagina. It could be a vaginal lesion and a vaginal cancer, so I biopsy that. Pap smear is not for vaginal cancer either. It can help. If it's positive, it can help, but a false negative Pap smear is not helpful. So let me back up just a little bit. So what is a Pap smear? A Pap smear is a brush that collects cells, and then they take those cells and they put them into a solution. And they swirl that brush and it spills the cells that came from the Pap smear into the solution. And then they take that solution and they spin it with centrifugal force and put it all the way down to the bottom of the test tube, and then collect that material and put it on a slide. And there's a lot more preparation involved, but they put it on a slide, look under a microscope. So that's a Pap smear. So that's called cytology. And cytology is never as accurate as something called histology, where you take an instrument and do a biopsy. So histology is where you take a piece of tissue and you freeze it, well, this is a frozen section, or you put it in paraffin wax and solidify it, and then you take this microtome, this real sharp scalpel blade, and cut it until you get deeper into the tissue, and then you take all those cutted specimens, put them on slides, and you color them, you use a dye, and then you look under a microscope. Way more accurate than a cytology. So histology, way more accurate than cytology. So if you ever, that's why when you get an abnormal Pap smear, they do a colposcopy and a directed biopsy, and the biopsy is histology because it's way more accurate. So if you have an abnormal Pap smear, it's not straight to surgery, it's straight to colposcopy, which is in an office setting under a microscope with magnification and with sometimes they use vinegar or they use a dye to identify the most abnormal area. So now you all can be doctors and do colposcopies. So usually early stages are treated with surgery and later stages are treated with chemoradiation. So chemoradiation, it's difficult to tolerate for these patients, but they're both done at the same time. We don't like to get patients who have advanced cervical cancer, not because of the patients, but because of the disease. It's very difficult to treat and have a good outcome. Ovarian cancer, so sometimes called the silent killer, because most of these patients are stage 3 or 4 at diagnosis. 70 to 80% are stage 3 or 4, and that means that their disease is well beyond the pelvis and usually up in the upper abdomen. Many of these patients will require bowel resections. Sometimes they'll require the spleen to be removed or part of the liver. Really big major surgeries to try to remove all the disease. The first surgery, it's called debulking surgery, is the best opportunity to give that patient a chance to have the best outcome. These patients survive. 30% of the patients will have long-term survival. So, that surgery is extremely important for those 30%. Unfortunately, we don't know which ones are the 30% and which ones are the 70%. So we treat them all very similarly surgically if we can. Early cases are curable. Obviously a stage 1 is much more curable than a stage 4. But most women are diagnosed with advanced disease. No screening tests. I did allude to the blood test. They have another one. It's kind of a screening test that a lot of the OB/GYNs do. It's called OVA1. It's basically 5 different proteins that are looked for, and there's a mathematical formula that's used to calculate the number, and if it's above 4.0 or less than 4.0, and if you're premenopausal, postmenopausal. But bottom line is, if you have a mass, most of the time they're going to do an OVA1, and they're going to do, and that will, it's only risk determined, it's risk factor. So if it's high, your risk is higher, and if it's low, your risks are lower. CA125, and so it depends upon age. So CA125, the cancer antigen 125, patient who has, who's 60, so postmenopausal woman with a CA125, and the number is above 35. So if their CA125 is 90 or higher, they have a 98% chance that they have ovarian cancer. So premenopausally kind of doesn't have a lot of meaning. So it may be elevated, as I mentioned earlier, in endometriosis. It's going to be elevated premenopausally for a lot of other diseases. Can elevate it. It's not very specific, and it's not a good screening test. You need to have a pelvic mass before it really has any meaning. If you have no pelvic mass, it has no meaning. The UK just completed a 10-year study that looked at screening ultrasound, screening CA125, screening pelvic examination, and found that was not helpful in any way, shape, or form. And there was 250,000 patients in the studies, in each arm of the studies. So it was very clear that as a screen for saving lives, so the endpoint was diagnosing ovarian cancer early and saving lives. And overall survival was not impacted at all. So it's pretty interesting. So right now, today, we have zero ability to screen for ovarian cancer, other than if the patient has symptoms. You have to have a high index of suspicion. You have to, patient has any of these subtle symptoms, you need to image, you need to examine, you need to rule out. And, sometimes that's going to require surgery to rule it out. So, I'd rather know than not know. Treatments, options, surgical, we already talked about. We're talking here about all GYN cancers. Depending upon the GYN cancer, sometimes you can just remove the cervix. For instance, I'll give you an example. If a patient has cervical cancer that can be cured normally with surgery, but the patient's childbearing hasn't been complete. So what we can do is we can remove the cervix, detach it from the vagina and the uterus, and then take out that diseased cervix and the surrounding tissue, and then reattach the vagina to the uterus. We usually have to put a cerclage, a stitch into the lower part of the uterus, so when they do get pregnant, that they will still be maintained. But that's a pretty radical procedure. But we've done it and had pregnancies with the patient. It's about a 50% success as far as pregnancy. 50% of the patients, it's an interesting statistic, 50% of the patients who go through that procedure will want to become pregnant after that procedure. Even though you do this huge procedure to preserve their uterus so they can get pregnant, try to screen for that, right? You want to not do that procedure unless because they have to get a hysterectomy after the childbearing complete. So, so they're committing to not only that surgery, but a C-section plus another hysterectomy. So it's 3 surgeries there as well. It's a lot to go through. So we want to screen, but only half the patients will actually want to get pregnant after going through that big procedure. And, of those half will take home a baby, so. So these, for early cancer, cervical cancer, we can do these tracheolectomies, removal of the cervix, radical hysterectomy with pelvic node removal. There's a lot of controversy on this, whether they can be done robotically. There was some, anyway, I won't get into it, but the bottom line is that radical hysterectomy in this population, standard of care is an open radical hysterectomy, not a robotic. It's a long discussion, that's why I'm hesitating. I don't really want to get into it other than say standard of care for cervical cancer is a radical hysterectomy done open today. That'll change, by the way. It'll go back because it was robotic for a while. They did a study and they looked at laparoscopic, so minimally invasive radical hysterectomy versus open. There's a lot of people in our college that didn't want minimally invasive surgery with robotics to do well. And so anyways, this trial came out and finally came up published showing that overall survival and disease-free survival was less than if you did it open. So if you did it robotically, the survival is less. So currently today, that's the bottom line. So we have to tell the patients, hey, you need to have this open, but I can do it as a robotic procedure. I think that data in 2008 to 2010 was the early, robotics began in 2006 for GYN. So in 2008, people were very inexperienced and probably did some cases that shouldn't be done robotically, or the techniques weren't as good. And so I think that's influenced the outcome of those particular patients, because I can tell you it's unlikely if the procedures are exactly the same, how is the outcome different? It doesn't make any sense to me. If you do an abdominal procedure robotically, how can the outcome be different other than recovery and complications and the stuff we'll talk about here in a second? So hysterectomies remove the ovaries, fallopian tubes, so endometrial cancer. Additional biopsies are done with ovarian cancer. Radiation chemotherapy may be the treatment of choice for certain patients, pre-surgery or post-operatively, especially for more advanced cancers. It's like cervical cancer, we go straight to radiation chemotherapy. So if they have, if they're not really operable, you can't cure the patient. So unlike ovarian cancer, cervical cancer, if you can't cure the patient and the patient would, if they did surgery and the surgery was successful, quote unquote, and the patient still needed to get chemoradiation, it's better for that patient to get her chemoradiation instead of doing the surgery and doing the chemoradiation. There's more complications. So it's better if you know that the patient's going to need radiation in cervical cancer to do the surgery. So in endometrial cancer, you do the surgery almost always. Ovarian cancer, you almost always do the surgery and then follow that up with chemotherapy or chemoradiation or radiation. So this is the most common major procedure performed on females is the hysterectomy. It's the definitive solution for most of the diseases we've talked about. In the end game, or the definitive procedure for fibroids, endometriosis, and all the cancers we talked about. About 650,000 cases done each year. It's probably a little bit less than that now. Most, at least at this, when I wrote this slide a few years ago, most of these were being done open hysterectomies for all the, you're talking about more complex surgery, but it doesn't necessarily have to be complex, but they were being done mostly open. It's because laparoscopic surgery had a low adoption rate because it's so difficult to learn how to do. The average OBGYN does about 20 to 30 hysterectomies a year. So it's really difficult to learn how to be good at something, doing it. So if you split up your hysterectomies and half of them you do open and half of them you attempt to do laparoscopically, it's tough to get very good if you're doing 1 or 1.5 hysterectomies per month. It's not a procedure that you can be good at. And so if you really kind of need to kind of commit one way or the other so you become actually better at abdominal surgery or laparoscopic. So advances in minimally invasive surgery has allowed more minimally invasive surgery because the techniques are better and the equipment's better. And so more GYNs are performing today, more GYNs. So today, About, at least in this area, 75% of the hysterectomies are performed as robotic procedures. And we'll talk about that in just a second. So there's 40,000 myomectomies performed in the United States annually. That's the removal of the fibroids. Most in the past have been performed. Obviously, the bigger ones still have to be performed open, but smaller ones are now being performed minimally invasively. Usually, it's because it's all sewing. You cut into the uterus and remove this smooth muscle tumor, and then you got to sew the muscle of the wall of the uterus back closed, and multiple layers. All that sewing. Laparoscopic surgery never could kind of compete with that, and the robot shines anywhere that you have to do sewing. So is sacrocolpopexy, myomectomy is where it shines, and that's why there's way more surgery for myomectomy being performed robotically. So advances for myomectomy, more GYNs perform myomectomy. These patients only get myomectomy or removal of fibroids as they're pursuing fertility. I do have occasionally a patient come in who's 60 or 65 and say that she wants a myomectomy. You know, she has a 10 or, you know, it's a symptomatic fibroid, and she just wants to keep her uterus and doesn't want to lose their uterus, and so you want the fibroid removed. I'm usually kind of resistant to that. I think the patient's making a poor mistake or a poor decision or making a mistake. So abdominal or approaches, surgical approaches to hysterectomy, as we talked about, minimally invasive. So that includes vaginal surgery. We didn't talk much about that, but vaginal surgery, conventional laparoscopic surgery, and Davinci or robotic hysterectomy. So minimally invasive surgery, that includes vaginal. There's less blood loss, fewer complications, shorter hospital stay, faster recovery, less scarring. Vaginal surgery, pros and cons. Minimal scarring, short. In fact, there's no scarring on the abdomen. It's all done vaginally. Less pain compared to abdominal surgery. Difficult to perform. I don't necessarily agree with that, but it can be difficult to perform. There's definite reduced visualization. I think the number is 50% of these patients who are preoperatively planned to remove their ovaries. 50% have their ovaries left because they're unable to visualize them or see them. I had a patient recently who had a vaginal hysterectomy within the last 5 years, and they planned on removing her ovaries because she was in her 60s when her hysterectomy was performed for an appropriate diagnosis, and I was seeing her because she had ovarian cancer. So that's the risk, is that you leave ovaries that should, you know, standard of care is to remove those ovaries, and they're left, and then they get cancer. Which is a pretty big deal. Reduced visualization, sometimes not indicated for certain patients. Obviously, women who've never been pregnant, who've never delivered vaginally, it can be difficult. That's a relative. I mean, it's not even a contraindication, not even a relative. It just depends. If they have large, big fibroids, you're going to have a tough time getting them out. Although we've done a lot of big uteruses. Taking them out vaginally. Cancer, it's contraindicated to do a vaginal hysterectomy. You know, there's not completely accurate, but for the most part, most cancer cases should not be done vaginally. And then, of course, the patient has some of the diseases we talked about: endometriosis, fibroids, large fibroids, adhesions, a lot of previous surgery. So here, this picture basically shows the difference between. So this instrument is a robotic procedure instrument. It's a needle driver, and I'll show you a picture here where, you know, basically that wristed instrument, it can move in every direction, and this is a laparoscopic instrument, and it can spin 360, and you're operating it out here on the extended end of there's a hand grip, and it can maybe angle in certain ways very crudely compared to, we're going to show you a video if I hurry up, of robotic procedures and how different they are. It's like my hand is this big, and I'll show you a picture. But here's open surgery, a vertical. Here's a phanostil or low transverse incision. And this is laparoscopy, or, I mean, that's more incisions than we do in laparoscopic hysterectomies. but robotic, there's 5. So dime size incisions, there's 5 incisions for robotics. The visualization's better. I'm 10 feet away from the patient. I'm looking into an eyepiece. It's 3D, high definition, 10 times magnification. So it's better than my own eyesight. The robot basically adjusts the focus automatically, so it has perfect visualization. Drawbacks of laparoscopic surgery, 2D, so you have 2 televisions, and then surgeons, everything's not intuitive, everything is counterintuitive. Instruments are rigid, instruments are controlled at distance, all kinds of issues, surgeons fatigue. Your assistant, which could be either another physician, which is rarely done, or it's a tech or RNF or nurse first assist, or maybe in a PA, can make or break the case. Yeah.
Why is robotic surgery better? You still got the doctor with hands in your guiding robot. What makes it better than the doctor not doing that and doing it?
Yeah, that's a good question. So, so as a surgeon, I'm controlling the camera and 3 arms. I'm like a 3-arm surgeon. Actually, I'm more like a 4-arm surgeon. So if I
Control all that, but with just 2 hands.
yeah, so you're able to, because that's how it works. Yeah. So I always used to say before robotics ever came around, if I had an arm growing out of my chest with a hand on the end of it, I'd be the best surgeon in the world. And we have that now. We have a robot that makes you a 3-arm. You know, the camera I don't count. The 3 arms that are actually working make it so. So we'll show you a video, what kind of makes it a little more clear as to why it's way more advantageous. Those arms, yeah, you're right. I can only move 2 arms at the same time, but I can remove the camera in and out anytime. So I'm actually controlling 3 arms. But the 4th arm is intermittent, so I can move it and retract and then go to my other 2 arms and operate. So,
Are you in the OR yet, or are you?
yeah, I'm just like, I'm where you're at and the patient's here. Yeah, I'm a step away. So the next best thing for me to have my hands inside the patient. The only problem with that is that there's a 20% complication rate just by making that incision on your abdomen. So the infection rate in that incision is around, in cancer surgery, is up to 20%. In benign surgery, it's about 4%. The other major complication is blood loss. And so the blood loss rate in those surgeries are 1 to 2%. In robotic surgery are non-existent. You know, 1 in 500 or 1 in 1,000. You know, very, very low. So just you look at those 2 complication risks related to surgery, and having I prefer to have my hand in there. Most of the surgery I've ever done has all been open, right? Because I trained and practiced most of my career over the past 24 years as an open surgeon. So I'm much more comfortable with my hands in there. But having learned how to do robotics, I found that it was better for the patient because there's less complication. They heal quicker, they get back. And when we look at outcomes, the oncologic, the cancer-related outcomes are better for the patients who get robotic surgery.
For a hysterectomy, why isn't it better to have a vaginal one done?
Yeah, that's a great question. So the American College of Obstetrics and Gynecology recommends all patients who get hysterectomies should be getting vaginal hysterectomies. So they make that recommendation. In the United States, there's less and less vaginal, since they made that statement, and that was about 5 years ago, maybe 7. Since they made that statement, the number of vaginal hysterectomies have fallen steadily. So now they're around 10 to 12% of all the hysterectomies in the United States are done as vaginal hysterectomies. Interesting. So why is that? That's because, yeah, you can do a vaginal hysterectomy, but is it the right thing to do? Can I do it as a procedure? So the big pushback has been about the cost with robotics. So a person who does robotics likes the visualization that they see and the fact that they'll take out ovaries every time if they want to take out ovaries, not be forced to leave ovaries because they can't visualize them. So ultimately, the size of the uterus, the ovaries or no ovaries, the disease that's present doesn't matter if you do it robotically. So let's go back to the statement that I said about numbers of hysterectomies. If you're a GYN, actively practicing GYN surgeon, and you do 20 or 30 hysterectomies a year, I don't know, anybody does, like, I just don't, as a surgeon, doing a hysterectomy 30 times a year, it's hard to maintain your skill set. So if you split that and you do, okay, I'm going to commit like our college, American College of Obstetrics and Gynecology, wants us to do all hysterectomies vaginally, then do them vaginally, but you need to commit all your cases to vaginal hysterectomy. You do all, you have to do 90% of the hysterectomies that you can do them vaginally. But that leaves you, say you do 90, so then it leaves you maybe 4 or 5 that you may be able to do another way, either open or robotically. So you do 4 or 5 procedures open, you're not going to be very good. And you do 4 or 5 procedures robotically, you're not going to be able to do those. You'll be incapable of doing those surgeries because you don't do them frequently enough. You're uncomfortable. So then you'll pick out cases that are easy to do, and they should have been done vaginally to begin with, and you're doing the easy ones to be robotically done just so you can continue to maintain any skill set. So what's happened in the United States across all specialties and across the United States in general is that people have said, look, we're looking at the big picture. The big picture is it's better for these patients to get minimally invasive surgery robotically because I could do much more if I need to, even though I could have done it vaginally. Now, this doesn't really apply for me because there are not very many cases that really should be done vaginally in my case, but I'm talking about general OBGYNs and overall. So most of those OBGYNs have said, look, I want to have skill sets that make it possible for me to be good at difficult cases that I would normally do open, I want to do robotically. We're not trying to replace vaginal hysterectomy, we're trying to replace open hysterectomy. And everybody agrees that's a good thing. So we take open hysterectomy away and make them minimally invasive or robotic. So that's what you want to do. But if you don't commit all your cases that you do into robotics, you're not going to be good enough to do the more difficult ones, and they'll be done open anyways. So you've kind of missed the boat. So if you're just doing easy robotic cases, there's no challenge, and when you have a difficult case, you're not going to be able to do it, and it'll be done open. Or you refer the case to somebody who can do it. In this community, there's somebody who can do it. There's several somebodies that can do difficult, benign hysterectomies on almost any patient that has disease of any kind and be done as a minimally invasive surgery. So I say to you, do you want to have a surgery that takes an hour to an hour and a half, and you're in the hospital overnight, and you have a 2-week recovery, and you'll be completely healed at 6 weeks? Or do you want an open surgery where you're going to be in the hospital potentially and have a 20% infection rate, a 1 to 2% blood loss rate where you get a blood transfusion? So let's make it a good scenario where you're out of the hospital in 2 days, maybe 3, and your recovery is 6 to 8 weeks before you go back to work. You have a lot more pain, you're using a lot more pain medication, you're not near as functional during that 6 or 8 weeks. As a patient, you're going to say, no, I want a minimally invasive surgery. Let's do that. So that's what's going on. The patients are pushing it, and the GYNs are pushing it because they want to be able to do those difficult, benign GYN cases. Mm-hmm.
No matter which way you do hysterectomy, you have to follow it.
Yeah. Zero. I couldn't tell you how much I get paid for a laparoscopic open or a robotic procedure, because I just don't pay attention to it. It doesn't matter to me. I'm going to do, and I think most of the OBGYNs that are out there kind of consider that as well. I'm not saying most, there's probably some that look at that, and it's important that, so you don't make a significant difference. I know this for sure. You don't make a significant difference whether you do it laparoscopically, vaginally, robotically. You do get paid more to do it open. So I'll tell you that. So the robotic procedure doesn't get paid any more than the other three, but it gets paid less than an open procedure. Open pays the most. And it's becoming less and less common to have an open hysterectomy in the United States. So to me, that's some evidence that maybe finance is not influencing the surgeons who are making the decisions. Right? So Davinci, state of the art, very expensive. The instruments are disposable. They're probably around $200. The key here is not to burn through all the, use, your one instrument set to do the hysterectomy and one instrument set to do the closing part. Yeah, it's just so that's an abdomen. There's sewing, but it's basically trying to show you that what the instruments are very precise, very good control. This is the surgeon's hands in the what's called the console. So in the console, the eyepiece, the hand pieces, and there's 7 or 8 foot pedals to control all the other arms and the energy that's used. This is one of the things I referred to, is that this wristed instrument, and all the instruments are wristed like this, is very much like my wrist, unlike the laparoscopic. So we just can't do the things that you can do. You can't do the things laparoscopically that you can do robotically. So eyepiece, this is the console. And eyes go in here. These are the hand pieces, the master control, 3D high definition. That's how big the instruments are. So I put my hand into an abdomen because I made a big incision. They're going to be a lot. So the issue is, why is it more painful? Because there's more trauma to the tissues, more trauma to the abdominal wall. And when I'm using an instrument like that has an 8 millimeter incision on the abdominal wall, they just don't. Most of the pain with surgery is abdominal wall incision, right? So you make a smaller incision, they're going to have less pain, but it's also trauma to the surrounding tissues that you operate on. And so, the point of that one is that look how small it is. It's pretty amazing. These are some of the other instruments, very tiny. This is just some more evidence. Better visualization, easier, faster suturing. You can't really even suture laparoscopy. You can, but it's inconsistent, not very good. Robotically, it's good. I was trying to remember. So at number 10, right around number 10 is where I actually it kind of clicked for me. So that was 2016. Case number 10. So when do you start feeling comfortable in using this? And I think, once you get it, it's visualizing and having your hands and being away from the patient. There's a lot of things that influence it. But I think by the 10th case, I felt like, okay, now I get it. I get like what we're trying to get. Now I wasn't where I wanted to be, but I could finally because it's like operating like this. You're operating this close to the patient's, instead of, arms out, an open surgery, your arms are way away from the patient, and you're operating and tying and sewing, and fairly crude. And robotic surgery up against here, and you have these tiny instruments. And so it's a completely different skill set to learn how to do it, but it does take a while. So probably, I think someone wrote a paper, said there was 500 cases before you really can be considered an expert at it. And the reality is there's probably a handful of people that get to that. So if someone says, okay, how many, I did 500 cases. Well, it took me 20 years to get to 500 cases. That's not very good. If you did 500 cases in a couple of years, then you'll get the skill set and be an expert at it. So it's all about intensity. It's like residency, a resident training how to do it. They learn because of the intensity of the training. It's a number of cases that they do every single day over and over, where they get that repetition. Repetition is everything in any surgery. The more cases that you do, the better you're going to be at it. Yeah.
So the robotic surgery is by little
Mm-hmm.
incisions. What happens if any of those organs are swollen? Or, I mean, does that, you have to change the way you do anything?
Yeah, so that's a great question as well. So what's the incidence? There's a couple different questions there, but what's the incidence of conversion? So those patients who start out as a minimally invasive or a robotic procedure and you have to convert it to an open procedure. Well, when you're starting out early on, that's a higher rate than it is. Like I've done between 4,000 and 5,000 cases now. So our conversion rate is very low. 1 in 500, very low. Once in a while.
That happens though with robotic surgery. Do you then have to go to the
Open abdominal incision. Yep. Your conversion.
can't do it vaginally?
No, it's too difficult to do robotically. You're never going to be able to do it vaginally. It's an open procedure. Yeah. So vaginal surgery can only be done in the most easy cases. Right, so it's the easy, small uteruses, not big ones with fibroids, none with endometriosis or minimal endometriosis. So they can't have a lot of disease present for a vaginal procedure to be done successfully. So robotic surgery is replacing abdominal surgery, not vaginal surgery. Vaginal surgery is going away because people don't want to, I don't want to say waste. They're not. They want to. Direct all their energies at learning how to do a very difficult procedure robotically. They're trying to get the experience there, and that's why vaginal hysterectomies, which are those easy hysterectomies, straight up small disease, small amount of, very easy to do.
You make it sound like it's like the surgeon wants to do it that way, not the patient.
So the patient's given up. So if I'm talking to you and I say, okay, you can have it. Here are the 3 ways that you can have a surgery. You can have open surgery, 20% risk, 1% blood loss, blood transfusion rate, 20% risk of infection. Whatever, there's a 1 to 2%. You can have injury to the bowel, or I can give you a surgery that has a 1% risk. And I usually get, how many of these you done? Well, I've done 50. Was that enough for you to be decent at it? Well, I think so. Which one do you prefer? I prefer to do as a robotic procedure. I mean, it's a conversation like that. Now, most of the people coming to me are coming to me because they know they'll get it done robotically, right? I'm getting referred the patient either because they have cancer or because I can do it robotically. They know that a minimally invasive procedure will be performed, not only attempted but performed. So I'm just thinking about all the other GYNs that are out there, how they might approach this. And really, if you're starting out, you probably want to approach this as, hey, I want to concentrate on becoming better because it's going to ultimately help all the patients down the road. We're talking about all this stuff right here, and that's lengths of stay, hospital stays, recovery, return to activity, and we don't really need to go through a lot of this. And we're way past our time, so I'm just going to blow through here. I did want to show a video of some robotics. So the videos. Well, I have a recording of every single procedure I've ever done. So I can, we can do a whole day of that if you like. Not everybody would like that, but some patients like pass out watching it. But that to me that's interesting, but it's not interesting to everybody. So you're kind of unique because you're interested in that. So let's bring up that video. I just have to get to the end here. Anybody else have any questions?
No, but I'm a success story from Dr. Pugmire. I had endometrial cancer in 2013, 8 years ago, and my gynecologist sent me to him. He was pretty new at the time at Britain, but he did my surgery. In 2 weeks, I was doing very well. I had 5 days.
Let's do the
Robotic.
robotic.
It was the easiest thing, and I've had friends that have had hysterectomies. years prior to that, and they would be off for 6 to 8 weeks, and so I definitely.
I'll tell you a story that kind of mimics that. So when the intuitive surgical first came out in 2005 and it became indicated to do robotic surgery for urology, they were predicting that the following year it would be FDA approved to perform in GYN surgery. And so I was doing, as far as all the GYNs, I was doing the most number of laparoscopic surgery in Lansing. And so they came to me and said, hey, we want you to be our first GYN in this entire area to do robotics, and we want to train you. I said, look, I'm too busy and not interested, and yeah, it might be good, but it's got a way to go. So they went directly to my competitor, the other GYN oncologist in town, and he did very few minimally invasive surgery to begin with, almost all open, and he learned how to do it. He got very good at it within a year, and people started flocking to him, wanted to do this new procedure. So I said, okay, I'll learn how to do it. So I learned how to do it. I said, this is not going to make any difference for me. It's not going to impact my practice. It's not going to change anything for me. So I did the very first patient, and I wasn't very good at it. I was terrible. In fact, I was terrible. I mean, I could do the procedure. I mean, I have high expectations, right? So I want it to be perfect. It took me a while to do the procedure. Laparoscopically, I would have done it maybe in an hour and a half. It took me about 3 hours. It was a struggle. I didn't get it. I didn't see the technique and how it was supposed to be done. But I said, okay, whatever. I got the procedure done. I'm learning it. That's fine. I was reluctant all the way. And I went into the room to see the patient. I said, she's not going to be any different than my laparoscopic hysterectomy. Went and saw her, and she's like, I'm ready to go home. Things are good. I feel so good. Let me get out of here. I'm like, wow, that's impressive. So none of the laparoscopic patients ever. So I said, okay, maybe a fluke. So I went to did it again. Next patient, same exact thing. Oh, I feel so good. I feel great. I felt like I didn't even have surgery. I want to get out of here. I'm like, wow, that's just nuts. And then it just happened over and over and over. Now, obviously, it's not 100% that way, but the reality is, so the torsion, the torque, so laparoscopically, when you put an instrument in, you got your hand out here, you got another person across the table, and you're looking and you're torquing and you're cutting. It's almost gymnastics, and it's a lot of trauma to the abdominal wall. And I already told you that trauma to the abdominal wall is why the patients have pain. And in robotics, it pivots on a point. All the pivoting is on one point, and it's all calculated by the computer, and it controls all the trauma to the abdominal wall. And so consequently, there's less trauma. You maybe do exact same surgery. It's way more precise, technically speaking, and that's why there's less blood loss, and there's less injury, and there's less trauma and faster recovery. That's the reason why, but it's way more precise. But these patients have less pain and discomfort as a result of that minimal trauma, including, you kind of alluded to the cauterization. Yeah, cauterization, they have other instruments. You can use ultrasound techniques, et cetera. I don't think it's a matter of learning how much of that you need to use in specific areas. And that's why experience is everything. Experiencing how those instruments work to their best is the important thing. You guys started. Yeah. Well, I operated recently a very close, one of the nurses that works with me very closely, and she was very reluctant. She had a 10-centimeter mass on her ovary, and she's seen patients come and go from robotics. She's a chemotherapy nurse, but she's been in my practice and she's worked a lot, and she's seen thousands of patients. And I think, so she had some reluctance just doing the procedure, and she finally committed to doing it. She may have been one of my best patients ever. She was back to work the next day. She goes, I just don't feel anything. It's like you didn't do anything. She goes, there's nothing. I'm a little fatigued later in the day. I didn't want her to work. I wanted her to take 2 weeks off. But that's some of the questions. You had to start that anytime. Are you already trying? we'll run this as I'm talking. Anybody have any
The
questions?
Davinci surgical system is the most advanced platform for minimally invasive surgery available in the world today. The integration of high-resolution 3D vision, wristed instruments, and intuitive motion control enable the Davinci surgeon to transcend the limitations of conventional surgical technologies. 3 network components comprise the Davinci surgical system: an ergonomic surgeon's console, a patient-side cart with 4 interactive robotic arms, and a high-definition 3D vision system. Seated at the console, the Davinci surgeon views a remarkably clear 3D image of the surgical field. The system scales, filters, and translates the movements of the surgeon's hands on the master controllers to 4 interactive robotic arms on the patient cart. The precisely controlled micro-movements of the Davinci instruments are enabled by the computer processors of the system. These dedicated processors perform millions of safety checks over the course of a procedure for enhanced surgical precision and control. Davinci EndoWrist instruments are designed with a unique wristed architecture that provides 7 degrees of freedom for a range of motion greater than even the human wrist. This proprietary design enables surgical maneuvers impossible with conventional laparoscopic tools. The system requires that every surgical maneuver is under the direct control of the surgeon. Redundant safety checks prevent autonomous movement of the instruments or the robotic arms. The Davinci S surgical system moves surgery forward with a new level of technical capability that enables minimally invasive surgery in complex procedures as never before. Davinci provides a streamlined surgical experience that benefits the hospital, the surgeon, the OR team, and, most importantly, the patient.
All right. We have plenty more, but we can answer any questions that people have. Thank you for coming. And, if you have any specialty, anybody who needs consultation with technical directly with robotic surgeons that we know that are very good, that are experienced, the bottom line is, it's an informed decision for all patients. So, you should at least have that as an option presented to you by your surgeon. And so your surgeon should offer robotics. Now the reality is that not all surgeons do robotics and not all surgeons feel comfortable doing it. So ultimately, it's between you and your physician to decide whether you want that. But certainly, in the intermediate 15 years of doing robotics, and I've been converted, there's no doubt. We did a case yesterday that, there's maybe a handful of people in the country that could do that procedure. And that's not a brag, that's just, I'm amazed by the fact that it can be done as a minimally invasive procedure. And so to me, that's the whole goal. This technology is going to continue to develop forward and be better, making it possible to do every procedure. So this is that's why vaginal hysterectomies are going away and laparoscopic hysterectomies are going away, because the technology and the expertise, the surgeons becoming better as we develop this technology, and so it makes it better for the patient. A good technical surgeon is good for the patient, so we have better outcomes as a result of that. And that's what all we want. We don't want to be good robotic surgeons, we want to have good outcomes for patients. And sometimes that message is not delivered the way I need to deliver it. That's the whole point of it, is that we want good outcomes. And if we can reduce complications and have better outcomes, that's our goal. And I think that's the goal of most surgeons.
And short recovery.
Short recovery and less complications, right. We want people to get back to their normal lives as quickly as possible. And if you do that in cancer, that's a big deal, right? These patients are being diagnosed with a bad diagnosis, and if we can get them back to their normal life as quickly as possible, so much the better. More life for them to live. So thank you for coming. Have a great day.